Good morning, everyone. I'm just going to try to make it look as good as possible. So thank you very much, Dr. Nzazi. It's my Swahili coming in. So I will just be giving you an update of so far what has been happening in the ESA region, because I am based in the ESA region, so Eastern and Southern Africa, and we've been doing some work, and I would like to thank all the countries in the region specifically for giving and reporting to the Global AIDS Monitoring Tool, because these are estimates from your countries, and we just kind of consolidate them and share with each and everybody else in the region. Next slide, please. I can do it myself. Try on technology a little bit. Okay, so that's me. That's a bit fun. So the overview specifically of the AIDS epidemic or HIV epidemic in the region. We have still quite a lot of number of people living with HIV in our region. We are still at 20.6 million people. We have at least 1 million children still living with HIV in our region. We have 12.6 million people, women, who are living with HIV, and young people at least 2 million. The new infections in our region are still at 670,000. AIDS-related deaths, we're still at 280,000. The ART coverage, I think also Dr. Kongensong has said about this a little bit, we're at 78%. PMTCT at 90%, actually depending on the countries, we have variations. And also want to say also the ART according to the variations, because at national level it looks really good, but if you go and do a little bit of a deep dive to the sub-national, we see a little different of a kind of a different picture in all of these countries in our region. So at least we still have people receiving ART at 16.2 million, and PMTCT coverage is at 280,000 women. So here is where the crux of the matter starts to get in this region. So we have progress from 2010 in controlling HIV new infections among adolescents in Eastern and Southern Africa, but we have insufficiently maybe will not reach the 2025 target, and we have not reached the 2020 target either at 90 in many of the countries. As you can see, maybe Eritrea is the only country that has done more than 71% reduction in new infections. And we have also Zimbabwe doing pretty well, and Zambia at 44% new reductions. But South Sudan, we have an increase of 26%, and Madagascar, unfortunately, at 235 new infections, like increase a percentage of new infections in the region. So the region has not definitely reached the political declaration. And most of you know that this is a new strategy, 2022-2026, where we're looking at inequalities and ending inequalities in order to support ending the new infections in the region. So our new infections among adults, as you can see that, they showed me how to do this. The light, maybe, not working. But just the orange, I hope not colorblind, the orange line. With current response, we're still at 500,000 infections in the region, hoping to get to 150,000 by the target of 2025. That's basically in 1.5 years to make a difference. So we need to reduce new infections by 350,000 in our region. So going forward and looking at our data and actually looking at the science we're going to be doing today and thinking or rethinking or repackaging what kind of programming we're going to be doing in the different age groups, I think this is a good idea to start thinking of how much we still need to go. So we have countries like Botswana, Malawi, Rwanda, who have made really good progress in reducing new infections among children. But still countries like Madagascar, as I said before, were still lagging behind. But at the ESA region, the Eastern and Southern Africa, we're at least at -61%. We've managed to reduce 61% new infections between the age of 0 to 14 in our region. So PMTCT in this region is actually working very well. And then 41% of the new infections in ESA occur in South Africa, while there's 34% that occur in 4 countries, Kenya, Uganda, Tanzania, and Zambia. So this is like the buckets of the biggest new infections that we have in our region. And some of the SR region like Zimbabwe, we have 4%, Malawi, Angola, South Sudan, we still have new numbers. But the others we have like 0% is because properly we don't have all the data. So I'll just be cautioning about that. At the end of the day, I think there's big buckets of really big countries that actually have a lot of infections in our region. And because our new strategy is really speaking about inequalities, and we have realized that treatment or prevention does not work very well in inequalities, and also because of the harmful masculinities which discourage men seeking care, we can see that the HIV and gender in Eastern Africa, new infections among women is actually between women in 15 and above, we have much higher than in men, either because of service delivery or service uptake, or just understanding the men masculinity in service uptake within these age-seeking groups. Coverage of antiretroviral treatment is pretty much steady, but not really giving us the results we want, because as I saw that in the first slides I've given you, we have not managed to reduce the new infections by even 75% in our region. Only a few countries have managed to do that, 2 or 3. But if you do a sub-national like data disaggregation, you see that these numbers are not exactly the same. So we are hoping at the end of 2025, in 1.5 years, let me make it just sound like that. In 1.5 years, I'm hoping that we could be able to reduce the new infections in this region. So about 2 in 5 new infections in our region, in adult infections, they're happening between the age of 15 to 24. I think you heard that from Ambassador also talking about this age group. And also 3 in 4 of these are among adolescent and young women. So basically, at the end of 1.5 years, we need to reduce new infections to 50,000 in this region, in this age group. But unfortunately, currently, as you can see, among boys 15 to 24, we still have 53,000 new infections. But for female, 15 to 24, we have 168,000 new infections, approximately. And in all young people, we have 222 approximately new infections, and these have to go to 50,000 by 2025. So I think we have our work cut down for us. So talking about adolescent young women, 15 to 24, they account for 35% of the new infections in this region. We have 3,200 new infections weekly with adolescent and young girls. And for men, young men, 1,000 new infections in a week. So as you can see, the estimated number of new infections between 15 to 24, South Africa kind of takes the biggest chunk of, still today, we have 51,000 new infections in South Africa. So in South Africa, every hour, we have 6 women and 6 young men getting infected in our region. And there are borders, so South Africa is not so far at the end of the day. All of us, majority of our countries border South Africa. So it's part of our problem too, if you want, or a challenge for us too. So the most infected occurs in 2024 in South Africa, 15 to 19. So you can see that the idea of having the age 15 to 24 is great, and we can lump them there, but actually they're not a homogeneous group. If you go to different countries, for instance, in Uganda, you have much more 20 to 24 and less 19 to 15. But in South Africa, it's a special case. 15 to 19 is quite high, new infections among adolescent and young people. So when you're doing programming and packaging for adolescent and young people, also we're looking at the prevention precision for each and every group we support is very critical. And of course, as I said before, in every hour in South Africa, 6 women or 6 girls get infected. Gender inequality also plays a big role in the epidemic in our region. We have the challenge of male and female, of course, uptake for services and also new infections, but also the change. So we see different, a decrease in new infections in our countries. Some of us have done so well, some of us maybe they don't have enough data, but at the end of the day, I think you can look at the changes in Eastern and Southern Africa. Between males and female, we can see that the change in female is much less than 50%, and for men, at least we are trying to get to more than 50%, so reduction in, we're at least like a 55% reduction in new infections among boys and young men. So most of infections, as I said before, come from adolescent and young girls, 15 to 24, except for South Africa, where we have 24 years old. And I just want to show this slide because when we talk percentages, it looks very nice, like 50% reduction, 10% reduction, but if you have the denominator, if you see the real number, it makes a lot of a difference. So this is like a real numbers of adolescent and young people in our region that are getting, as I said, getting infected every day. So if we look at 10% of new infections are coming from adolescent and young people, if you put that, qualitative that into real number, I think it makes a lot of a difference. So in South Africa, like I said, we have 238,000 girls getting pregnant, getting infected every year. This is a lot of young girls that we are missing out on our programming. And also, the other thing that to look at when you're looking at the adolescent and young girls, so we have adolescents who are married at 15 already, and adolescents who are married at 18 years old already. So this is a risk factor too. So because we like to lump it, like adolescents and young girls. Some of these are cohabiting, some of these are already married, some of these are already mothers and though they are children. So looking at this data, you can already start to see that this early sexual debut, which takes place in the marriages, already started very early in some of these age groups. So for instance, in South Sudan, 51% of adolescents age 18 years old, they are already married. And then we're planning for them, saying that they're adolescent and young girls, but they are actually in cohabiting or in marriages. So our programming has to be also different in how we work with these ones. And in Mozambique, we have at 52.9% new infections coming from this exactly age group, 18 years old, who are already married. So I think, or in association or in cohabiting. So I think this is also some of the data we have to really look in the packaging when we're working on our programming for adolescent and young girls. Sexual violence also plays a big role in our region. For instance, in Namibia, if you look at it's the highest one that we have, more than 55%, almost 60% of age 15 to 19 who actually have experienced sexual or physical violence from a partner or a husband. So these are all the kind of inequalities that help or actually kind of aids the support to uptake of services for this age group between age 15 and 24. And then knowledge. At least I will not be so much into, I will not be too critical about it because majority of the data that come from knowledge in our countries are DHIS, and DHIS is maybe 10 years old in many of our countries. The best we can do sometimes is a mix or fears in our countries that give us a behavioral change, but majority of the data that we have, pretty much the knowledge on HIV prevention or HIV treatment is pretty low in most of our countries. The only maybe country that is pretty much doing okay is Kenya and Rwanda, but the rest of the countries in our region, the knowledge on HIV and prevention is almost, it's still very low. Even Zimbabwe, with very few new infections, the knowledge is still not there. So that's something to think about too. So here are some of the remarkable progress in declines we've made in the new infections among 0 to 15 years or 14 years old. I think the PMTCT cascade in our region is working, not to the maximum that we can. Now we have the Global Alliance to accelerate this. A few of our countries are doing very well. The 10 priority countries in the region are actually kind of almost getting there. Botswana is one of them. Namibia is coming actually quite high in reducing the new infections among adolescents, among children. But at the end of the day, I think with PMTCT coverage at all these countries, as you can see, we have almost like at 92, 91% from 2010, where we've been pretty much like 52% of the coverage in the region. But through the, up to 2021, we see a lot of progress in the scale-up and also coverage in PMTCT. We are at 78,000 coverage or people who have been reached. We still have to go to 30,000 in the population groups in our region between this age group. So we have, maybe 50% reduction, pretty much, in the next 1.5 years. So these are kind of the priority countries in Eastern Africa that account for almost 77% of the new infections in 2021 estimates. And the red ones are the ones that had the highest prevalences. So we have South Africa, which is at 18%. We have Zambia, which has 10%. We have Zimbabwe, which is 11% We have Lesotho, Botswana, Eswatini, and Namibia still have very high prevalences. Even if they are small countries, but the prevalence is quite important because they are our neighbors and we work around the region. There's a lot of movement and migration in this region. But this could be also a positive thing that they're keeping a lot of people who are HIV positive on treatment. This is a good data for also for treatment, ensuring that people are actually kept on treatment and living longer. So VMMC, I think it's a win-win for this region. We have a lot of countries that are actually practicing male circumcision, and a lot of them have achieved quite a lot. And as our data is showing, we have at least most of the countries in the region, in the calculated number, we have actually circumcised almost 30 million men in this region. It's just that to convert that to the introduction of new infections in our region. It's one of the works that's going on and seeing how well our 15 to 19 or 20 to 24 age groups, the triangulation or the relation between new infections in this age group, it's helping us in the population of adolescent and young girls, and how if we overlay that, we see if this new VMMC supports our reduction in new infections in the region. So this is the kind of the distribution of infections and sex between 15 to 49 in Eastern and Southern Africa. We have the remaining population, that's the adolescent and young girls and the boys I've been talking about, but then we have these clients of sex workers and sex partners as part of key population that actually bring about 25% of new infections in this region. We have transgender women with 2%, men who have sex with men, 3%, people who inject drug use, 3%, and sex workers themselves at 13%. And then, of course, in female and male demarcations, we have at least still 28% of females in this region, 20 to 49, they bring 28% of new infections. And 25% of them also come from 15 to 24. And then the other groups are pretty much, they're important also with the percentage that they bring. But as I showed you the slide before, it's the numbers that makes the difference. So the 1995 treatment targets in our region, I think most countries have done very well. Treatment is the first 90, second 90, the third 90 is working pretty well in our region, but that hasn't really converted into reduction of new infections. So treatment has really not worked as prevention yet for us. So looking at different, and I've said that at national level it looks very good, but if you go to sub-national level, these numbers totally change in each and every, I don't know, province or district where you go. These numbers change. So at the national level, yes, we are doing very well. And the regional level, we are doing very well. We're at 90, 87, and 93. But at the country level, this number changes in different ways. And if we had 93% of new infections or a virus-suppressed population in our region, we'll be seeing a lot more dips in new infections, because if our people are virus-suppressed, that means U equals U. So this is also working in progress for us. So we'll talk about, we've made good progress for the 90. We have at least about 78% access to antiretroviral in our therapy in our region, and 73 of those are virus suppressed. So we still have the gaps, and we have 1.1 million people who still don't know their status. We have 2.2 million gaps in our second 95, and 2.7 million people in our third 90. And some of these slides I will share, but the ones that I put on stars is something that's to really like rethink and look forward to, and to maybe, I don't know, unpack or just have a shift on how we manage them. Sorry about that. So on the treatment cascade, I think our men are still lagging behind. This is not rocket science. I think everybody knows this. I'm really sorry that I keep on repeating this, that men are always lagging behind. Men are always lagging behind, and we have to do something about that to bring it to the, to support the cascades. I mean, in many cases, it's of course women in the facilities and in treatment, or one way or the other. But I think the our male counterparts are pretty much lagging behind. So this is kind of the cascades for the 95 so far. And then also Ambassador talked about this data in these countries in the region. So we have Eswatini, Rwanda, Zimbabwe, and Namibia. That's shown really tremendous progress. They're even going to 25. Some of us are still at 90. They're really moving to the 25% target. So on half of the countries in Asia, like every 7 in 10 people access antiretroviral treatment in our region. I think that's a huge success. Like in each and every 10 people who are positive, 7 of them can have treatment in our region. I think that's a very good progress. And this is some of the countries that are actually giving us numbers. It's my last one. Okay, I'm out. PMTCT coverage, I think this is very important. I'll just finish, I think this is one more slide and I'm done. Because we are moving towards elimination in a few countries, and also, like I said, Botswana and Namibia are doing very well. They are also validating themselves to have less than 5% of reinfections in the region. So this is kind of the coverage that we have in our region. Yeah, maybe I'll just move on. Oh, I talked about the sex workers already. Just the last slide maybe is to speak about the human rights related that continues to hinder our progress in the region. I think if you look at this, sorry, I'm moving mine, I'm not there. This is going to be my last slide. If you look at this slide, with all the work that we've been doing for treatment, prevention, and PMTCT in our region, I think this is one of the biggest challenges that we have on the policies and laws that are not allowing us to improve our coverage, or just to even just reach the people that we want to reach, whether it becomes prohibited, or is it part of laws that don't work. It becomes part of age disparities, or becomes part of age, for service uptake and service delivery. So for me, I'll just leave it there. But I think for us going forward, and moving to those slides that I showed you with the stars, if we have to get anything done on any of those, I think these human rights issues, gender, has to really work in our region to make the difference. So the soft spots, the soft issues, the critical enablers that we need to push forward. Thank you.